Hello, everyone, and welcome to Unit 3 or Week 3 of our CCMA course. This week, we will be focusing on administrative medical assisting. So, while you will certify as a certified clinical medical assistant, which means we'll focus more on the clinical side of things, there are still some administrative tasks that you have to be familiar with and know how to perform. We will be drawing heavily from NHA Module 11, which is the administrative assisting module, as well as Chapter 7 through 11 from our Hartman textbook. These are some key terms that you'll want to be familiar with for the CCMA exam. We will cover these as we go through this presentation or as I go through this presentation, but here they are in one place to kind of make that a little easier for you. We will be discussing EMRs and EHRs, so the electronic records, the revenue cycle from beginning to the end, appointment scheduling, patient interactions, which we'll talk about patient interactions in every unit we cover because that is a priority for any healthcare professional. And then some minor billing, coding, and insurance things. We'll kind of touch on the basics of that. Medical assistants are very sought after because of their versatility and their ability to work both in the clinical and administrative sections of a clinic. So even though we, again, will focus on the clinical aspect of things for this course, there are still some administrative skills that you have to be familiar with. So appointment scheduling, managing referrals, maintaining accurate records is vital. It's crucial. Some minor billing and coding things and understand how that works, how it affects everything. And then insurance is a big deal. Okay, so understanding the technological needs of the medical office is really important for the medical assistant. Practice management software, which we'll kind of go a little bit into in the next slide, is the electronic system that manages like patient scheduling, billing, insurance, pretty much the entire revenue cycle. Examples are things like Athena, Cerner, and Epic is probably the most common around here anyway. Electronic prescribing, so prescribing electronically those prescriptions, which we'll cover more when we get to our pharmacology unit. Telehealth and virtual visits. And a lot of this is electronic. So we'll kind of talk a little bit about paper records, but most places now have electronic things. So there's your PMS system again, practice management system. Scheduling is also another thing that I don't think I mentioned in the last slide. Registration, patient demographics, and insurance, billing, which is all part of the revenue cycle. I also want to point out when I'm saying electronic records, a lot of times people will say EHR and EMR like interchangeably, but they do have very different meanings or very specific meanings. So the EMR, or the electronic medical record, is the patient's chart in a single practice. So whatever facility you work in, you will be documenting in an EMR, meaning that is that specific patient's chart. The EHR, or electronic health record, is a more comprehensive record that is shared across multiple organizations with multiple providers. So, for instance, if you were to refer, if you're working for a primary care practice and you document in the EMR, but you refer this patient to, let's say, a dermatologist, that dermatologist will have access to those records via the EHR, or the electronic health record. However, a lot of people use these terms interchangeably to mean the same thing. And again, all of this has those same functions, whereas you have all of the digital records, prescription tracking, appointments, all those things. And we're going to talk a little bit about paper records in the upcoming slides. However, most places are electronic due to the CMS, or the Centers for Medicare and Medicaid Services, offering financial incentives to switch over from paper records to electronic records. So there were financial incentives for that, and then eventually it became there were consequences for not having electronic records. So most places now will have electronic records. They're just really not likely to have paper records anymore, but you may come across it. So we're going to talk a little bit about that. So electronic versus paper records. Electronic records are stored on secure servers or cloud systems. They are accessible from multiple locations. It definitely assists in collaboration with other team members, as well as other even specialties. It has automated backups. It has encryptions and like controls for confidentiality. Whereas paper records are physical, they require physical space, like a dedicated space to that, to store those records. And then it's limited access. One person at a time can hold the chart, and it can be somewhat tedious. There are still some practices that if they do use paper records, it's probably like a hybrid approach where they have some paper for certain things, but electronic for other parts. If you were to go to work somewhere that did in fact have paper records, especially when it came to documenting, then there is a right way to document in a paper record, and to specifically correcting errors in a paper record. If you are documenting in a paper record, you have to be sure to put the date and the time. That is really important for the care of the patient, but also for legal reasons. I always say that when you document, and I'll probably say this again later, but when you document, always document like you're going to read this 5 years from now. And in 5 years, will you be able to understand what was happening? If you read it 5 years later. So make sure that your document is accurate, and make sure that it is clear enough that you understand what was happening. If it's a paper record, you have to put the date and the time. Whereas an electronic record, it date and time stamps it for you. It also like marks that you're the person who's writing it. Whereas in a paper record, you'll have to sign that you're the person doing this documentation. If you were to make an error in that, then you would just draw a single line. All paper documentation would have to be in pen, not pencil, because there would be the risk that somebody could erase and rewrite something that you wrote. So it would have to be in pen. And if you made a mistake, you would have to draw one line through that, initial that it was an error, and then correct it underneath. So you would write error correction near the mistake, and then enter the correct information, or and then initial and date that as well. You would also want to make sure that you leave no space anywhere in that paper documentation, because you don't want the risk of someone coming in and writing in that space. And we never ever use whiteout in a paper record. Electronic records are, unlike paper records, are typically stored like in the cloud with real-time backups. Paper records, however, are stored in the facility in some type of way. And then how it is organized depends on that facility, but the most common are filed alphabetically, meaning that it is organized by the patient's name, typically last name. However, that can run into some issues for mistakes, especially if they have the same last name, especially if they have the same last and first name. You can really run into some errors. And if you have a lot of patients, that's going to take up a lot of space. There is also numerical filing that gives each patient a unique medical record number. And so then they're put in or filed by that number. And then, of course, there is a color coding system that's possible. This is, again, you would need not a lot of patients for that because that would really be a lot. But if you had a color coding system, you assign certain records by certain colors. Um, Medical records are typically structured in two ways, either source oriented, which means it's organized by the source. So, like all of the lab results are together, all of the physician notes are together, just kind of making that really quick to access specific types of data, versus problem oriented records, or it may be abbreviated POMR. You may see it that way. Focuses on the individual patient's issues. And a problem oriented record has four main components. I have seen NHA questions related to this, so you are going to want to be familiar with the problem oriented records for sure, and the four components. So the first one is a database. In that database is the patient's demographic information, so like their name, address, phone number, all of that. Their chief complaint, like what brought them in, any medical history, exam findings, all of that is in what you call the database. And then problem list, so it's numbered list of problem issues, serving as like a focal point for the documentation. And then the treatment plan section are management strategies for each of those problems, so how they're being treated, and then progress notes, which are which track like patient status, and that is in the SOAP form, which stands for Subjective, Objective Assessment and Plan, which is actually uh, coming up on a slide, and I'll go through that in more detail. Um, So, some key medical record documents that you also may see, especially if you're doing source oriented, you'll see lab reports, which of course have all of the laboratory tests ordered for the patient and their results, radiology reports, all of the imaging studies ordered and their results, patient flow sheet, tracking patient movement throughout the facility, what all was done. Encounter notes. Encounter notes are what typically the billers and coders get their information from for billing purposes, because it is usually a detailed account of the visit. It has the assessment and the care plan for the patient. So it's sometimes called a super bill as well, and it typically has those codes on them. Oh, I see that it's in there 2 times. So encounter encounter notes or encounter form and super bill is the same thing. Um, and then again, the problem oriented medical record can a lot of times be documented in SOAP, or we call SOAP notes, SOAP format. So subjective information is anything that is provided by the patient. It's what the patient says it is. Commonly the chief complaint, because when we ask about a chief complaint, we typically say, "What brings you in today?" And that is an open-ended question, meaning they can tell us and give us a bunch of information related to that. A lot of times we put the chief complaint in quotations because it's what the patient says. If we ask something like, "Tell me more about that," that would be a subjective information. Their demographic information is considered subjective. So the phone number they give us, the address they give us, those are all things that they tell us. Their description of their symptoms, like their pain level. So if they say that their pain level is a 10 out of 10, we would document that, even if they don't seem like they're in pain, because we can't actually feel that pain. That is subjective information. The next one is the O, which is objective information. And objective information means it is observable by you. It's observable, measurable data. So that's things like vital signs. So if we take their temperature and it is a fever, we can document under the objective information that they do indeed have a fever. Other things like physical exam findings, lab reports, things like that, anything that's measurable is objective. Assessment would be the assessment data from the provider. So that would be their overall assessment, physical assessment, and then of course their working diagnosis, what they think may be going on with the patient. And then the P would be the plan or the provider's treatment strategy. That's things like what tests are ordered, what referrals are made, what medications are prescribed. Okay, so moving on to appointments. Effective appointment scheduling is crucial for any healthcare facility to run effectively. It is so important because if appointments are not scheduled correctly, that means that things are not going to run smoothly. The patients are going to be upset. The provider's going to be upset, especially if things are like double booked or like you have so many patients and not enough time to see them. Everybody's running behind. Nobody gets a lunch break. That's a mess. But you also don't want it to be the other end of like there weren't enough patients scheduled, or you scheduled patients in a longer slot than they needed, and so then there's big gaps of time, because then that means that the clinic and the provider is not making money that day. They're not bringing in any income, and that also can be a problem. So understanding how to schedule appointments correctly really is important for how a clinic uh, works, and how efficient that clinic may be. So even if you're working as a clinical medical assistant, you are still going to be scheduling appointments. So you need to understand the way appointments are scheduled, and then also the types of appointments that are scheduled. So some different scheduling methods. It just depends on what facility you work for. But some different methods are time scheduling, meaning that each patient comes in at a certain time. So maybe one comes in at 9, one at 9:15, one at 9:30. That's time scheduling. The most flexible type of scheduling is wave scheduling. And that's multiple patients scheduled at the same time. So typically it's 3 patients at a time. So you'll have 3 patients at 9 a.m. and then they're seen in the order they arrive. That way, if somebody was late and didn't get there till 9:15, it really doesn't matter because 2 other patients can go ahead and be seen. So having a patient be late does not really throw off anything, which makes it really flexible. Um, then there is modified wave, which kind of has a little bit of a staggered appointment time. So that's typically 2 patients scheduled like at 9 a.m. and then one scheduled at 9:30, and then 2 patients scheduled at 10 a.m. and one at 10:30. So again, like that kind of gives you some flexibility. Not as flexible as wave scheduling, but it does kind of accommodate both kind of waved and timed. And then there's something called cluster scheduling or grouping. And that is when a provider wants to see a certain type of patient at certain times. So maybe all physical exams are in the morning, or all post op appointments are in the afternoon. And they're just scheduled that way. I've, of course, been to places where they say, oh, they only see this type of patient on Tuesdays, or then that's just called cluster scheduling or grouping. Double booking, which is not on this slide, but double booking would be scheduling 2 patients at the same time, which is something you try to avoid if you can help it. However, if it is an urgent appointment is needed, sometimes that has to happen. So in order to be successful in scheduling, you need to make sure you determine like who needs to see what provider, how urgent that is, and when it needs to be seen. Make sure you're selecting the appropriate appointment slot, because certain appointment slots have longer times and certain appointment types need longer, and kind of balancing that, which can be tricky and difficult to learn. So some of those types of appointments: new patients. New patients are anyone who hasn't been seen by that facility or hasn't been seen there in 3 years. If they haven't been seen in the last 3 years, they're considered a new patient. And in that case, they need a new patient appointment slot, because a lot of times new patients take up to 60 minutes, because they have paperwork to fill out. They have to update all their history, their medications, all of those things. And then, of course, how it is billed is different if it's a new patient. Established patients that have been seen anytime in the last 3 years typically don't take as long, maybe 15 minutes. Comprehensive appointments, so that's things like they are there for a physical exam, a full exam, or some other type of appointment to address any type of complex condition. Those can take 45 to 60 minutes. Preventative care or wellness visits, that's for things like just annual checkups, vaccines. Those can take 45 to 60 minutes because they're going through like their full screening questions, all of those things. Urgent appointments, so like maybe they were worked in for maybe complaints of UTI symptoms or something like that. Those typically take about 20 minutes. Virtual appointments or telehealth appointments can be worked in as well if it's something that they don't need an exam for, just need to talk. So that could be something like a follow up for new medications. Just, hey, I'm doing well on this medication. Okay, here's a refill. Those don't typically take very long. It can be worked in the schedule. And then when a facility has a schedule, they do oftentimes work in non-patient related time, like administrative time for providers to return phone calls, to chart, for meetings, things like that. Sometimes that schedule is kind of blocked off for some of those things. If you are the person screening phone calls for patients, if an urgent appointment call comes in, it's really important to know how to effectively screen that situation to determine the appropriate care for that patient. When the call comes in, you have to get the patient's name and contact information. And when I say contact information, I mean a reliable phone number. Yes, if they are an established patient, you probably do have a phone number on file for them, but you need to determine and confirm that that is the number they want to be called back at, because sometimes they have a new phone number or they're at work instead and they want to be called back at work or something. So you have to get that information. You want to get the chief systems or chief symptoms or what the problem is, the reason why they may need a visit, how urgent it is, like when the symptoms started. If this is something that's been going on for a month, it may not be that urgent and we can get you our next available appointment. If it's something more serious, may need to be worked in. It is also really important to get their current location. Again, you probably have an address on file if you're looking at a chart, but that does not mean they're at that address. They could be at work, which is somewhere closer to the clinic or further away or something like that. So don't assume where they are. Always ask and get that, because if you're like, oh, we can work you in the next 20 minutes, but they actually work an hour away, that's not going to work. Make sure that they have transportation. Again, if you want to work them in on the schedule, don't say, can you be here? Or don't say, we'll see you in 20 minutes if they don't have transportation for that. Make sure that their insurance, we always do that with any phone call. We make sure insurance is the same and it is active. And then if it's a more severe emergency, we follow emergency protocols. So for emergency calls, we determine if the phone call is life-threatening. If so, we need to tell the caller to hang up and dial 911. If they cannot do that themselves, then you will stay on the line with them and then have a coworker call 911. And you may be on both phones answering questions, being a mediary, really, making sure that help gets there. And you'll want to make sure that it is documented appropriately how you did this. But we never want to get an emergency phone call and tell the patient to hang up and call 911. And if they say they can't do it, we don't want to just hang up on them and not take care of that. You need to make sure that you're providing that care and that you're documenting that. When a provider and a patient, when a provider offers an appointment and a patient schedules an appointment, they then enter into a contract. So if the provider does not, or if they take that appointment away, that's breaking that contract. Just like if a patient doesn't show up for that appointment, that is a breach of contract. So that has to be documented and documented appropriately. So if the patient calls to cancel, you want to make sure that you document that it was canceled. If they will give you a reason for the cancellation, you note the reason. We always offer to reschedule. Um, and let them know that it may be a later appointment, because often appointment slots are not available as quickly. If they no show, meaning they didn't call to cancel or reschedule, we definitely have to document that for legal purposes. Um, if it's part of your practice policy to follow up, you want to make sure you call that, try to get an answer as to why they did not show up. It could be something as simple as they forgot, in which at that point you would want to make sure that they are in the system to get phone notification, text notification, email for all appointment reminders. If it was a matter of finances, kind of see what's going on with that. Like, there could be things that you could help with, so that they can make their appointments. If there is a no-show fee, which a lot of practices do have, if you don't call and cancel, or even if you don't cancel within a certain amount of time, there is a fee that will be applied. And you can let them know that fee was applied. For repeated no-shows, the facility has the right to dismiss the patient from the practice. And if that is the case, then they would send a certified letter, which means that the patient or someone living at that address would have to sign for it and send that back, saying that they did receive it. And then it will just say that in 30 days, they'll no longer be allowed to make appointments at that facility from repeated no-shows, because, again, that is a breach of contract. Okay, so the revenue cycle. This is crucial for any medical practice. It includes both administrative and clinical tasks. It goes like from the beginning to the end. So as soon as the patient makes the appointment until they receive a bill or pay the bill, all of that is part of the revenue cycle. And medical assistants play a very important part in this process, all throughout the process. Whether it's scheduling appointments, whether it's verifying insurance, whether it's documenting appropriately, making sure that all of the details are in place are really important for the revenue cycle, and making sure that it is done correctly. Okay, so the first part of the revenue cycle, after the appointment is scheduled, the patient comes for the appointment. The patient checks in, and how that goes is whoever is at the front, the reception, which can be the administrative medical assistant or clinical medical assistant or just the receptionist. Either way, you want to greet the patient. And once you greet the patient, you'll confirm their identity, who they are, to check in. Get their updated demographics, name, address, phone number, all of those things updated. And so that you can make sure they are who they say they are. For safety purposes, we get emergency contacts, address and phone number, so that we can communicate with the patient in the future. And then we'll want to get their insurance information. A lot of times we'll need a copy of their insurance card and or their driver's license. Not and or, but and their driver's license. We will also have to verify their insurance. And I'll talk a little bit more about that in a later slide. Collect any copays that they may have, or any outstanding balances, any required payments. Complete any forms that may be necessary. Make sure they get their patient's bill of rights, sign any consent, their HIPAA compliance forms, and then notify any clinical staff that they are there and waiting, so that they can be roomed for their appointment. Patient interaction. When the patient arrives, we want to make sure that they feel welcome, and to reduce any anxiety. Again, patients are not there typically just for fun. A lot of times they don't feel well. They're there for labs. They're there for checkups, something. And so we want to make sure that they don't feel anxious and nervous about that, or try to make them feel as comfortable as possible. Acknowledge them and greet them immediately. Verify who they are. Making them feel welcome is really the priority. So here's your lecture assignment for this week. So I want you to reflect on your own healthcare experience. So think about a recent appointment you attended. What did that clinic do that made you that made an impression on you? Whether it was positive or negative. If it was negative, what could they have done better? What improvements could have been made? And then question 2 says, what do you think happens when a patient has a good experience versus a bad experience at a healthcare facility? Okay, so insurance verification. Why do we have to verify insurance at every visit? This is really, really important to make sure that the clinic or the facility is getting paid. That is essentially it. And if the clinic doesn't get paid, then you don't get paid. So it's something you want to make sure that you do. Insurance plans change frequently. Patients may not even be aware that their insurance plan has changed or how their coverage has changed. And that is very true. So verifying it before they're seen also reduces and prevents any surprises that the patient may have with any unexpected costs. Benefit periods may change. Their financial responsibility up front may change, especially if they switch to a different plan. They may have a different copay. So all of that is really important to make sure that that is done. So how we verify insurance is when the patient comes in and we have their insurance card and their insurance information, you can go on the insurance provider's portal or website, type in the patient's information, and it should tell you fairly quickly if that insurance is active and for how long. And we typically document that or scan it into the record so that we have it in there. We used to have to call, and you can still do that, but it's much quicker to do it on their web portal. But we used to have to call, type in all the numbers, and it was like an automated phone system to do that. But you can check that fairly quickly just to make sure that's done. And you want to do that before the patient is seen. If their insurance is not active or they have no insurance before they're seen, I mean, if you don't find out until after they're seen, then they're going to get a bill that they probably did not want or are prepared to pay. And then if that's the case, they don't pay, then the clinic doesn't get paid. So it's really important that this is done before the patient is seen. Referrals. So depending on the type of referral, a lot of times if it's a primary care provider or a family practice, they're going to send referrals for anything that is needed to like a specialist. So if they need to see a cardiologist or a dermatologist. This is a big part of the job as a medical assistant. Lots of referrals, especially if you're working for primary care. And so when you're doing a referral, you have to send over, and a lot of times there are specific referral forms you fill out, but with that referral form, you will send over the patient's demographic information, so their name and their address and their phone number and all of that, their insurance information, the referring provider who's referring them and why. Typically there's a diagnosis code accompanied with that, like why they're being referred to this specialist. Any clinical information and clinical notes. So the provider's notes would be sent over as well. If an insurance authorization is required, that would be sent as well. And we'll kind of talk about that and a time frame for the appointment. So when that is needed. So if it's a regular referral, it's not urgent. Typically within 2 to 4 weeks, they may get an appointment scheduled. Again, depending on the facility is whether or not they let you know when the appointment is, or if they just call the patient and schedule that appointment. An urgent referral would be one that is needs attention pretty quickly, but not so urgent and needs to be done today. So that appointment should typically be scheduled within 24 to 72 hours. And then a stat referral means that it needs immediate attention right now. They need to be seen today. Oftentimes with a stat referral, you're sort of foregoing sending a referral form. You are instead calling that clinic, speaking to that provider's nurse or medical assistant, or even the provider themselves, and letting them know that that patient needs to be seen. A lot of times they'll have to be worked in on their schedule. I frequently have had to like my provider wants to speak to that provider, and so like navigate those phone calls so they can talk to each other about the urgency of this patient being seen. Utilization management review, that is for things like pre-certification and pre-authorization. Those are also two terms that are often used interchangeably, but they do mean different things. Pre-certification is the insurance company determine if a service is medically necessary before the service is provided. So that's things like surgeries, things like MRIs, CTs, advanced imaging like that, certain medications, hospitalizations. Those are all pre-certification. Pre-authorization is the review process that determines medical necessity, as well as if the service will be covered under the insurance, meaning will they also pay for it? And so that includes verification of their benefit coverage, their eligibility, and medical necessity. And so those terms are a lot of times used interchangeably, but they do mean different things. And then depending on what you're doing it for is whether or not you need a pre-certification or a pre-authorization. And the steps to that are identifying the services that are required, what type of review is needed, gathering all of their essential information, their demographic information for the patient, clinical documentation, diagnosis codes, especially. Have to have diagnosis codes for these, and CPT codes, which are procedure codes. Submit that request in the preferred method, depending on how the insurance wants it sent, whether they want you to call over the phone, fax it to them, their web portals. And you can track the status of these these either pre-certifications or pre-authorizations, depending on what method that you did. And then you would want to document any outcomes, including they always give you an authorization number, and a timeline that says it's approved from this date to this date. Those have to be documented in the patient record. If it was denied, the reason for denial would have to be in there, and then you would want to communicate that to the patient. So if you're doing this for imaging, let's say for an MRI, and so you have all of this done, insurance approved the MRI, they give you an authorization number, and they say it's from this date to this date. The patient needs to know that it has to be done by this date, that it's approved by then. Because sometimes, even if you schedule the appointment, if they cancel the appointment or reschedule it, they may do it outside of that window and it won't be covered, and that'll be a whole mess. Trust me on that. I speak from experience. Documentation. Let's talk about how significant it is to have timely documentation in healthcare. There is the old saying, and I say it's old, but it's not old because we still say it all the time. But if it wasn't documented, it wasn't done. It's also really important that the documentation is done as soon as possible, because it will minimize errors. You don't forget. It's very specific. You make sure it's done and done correctly. Documentation is so important for legal purposes, but also for the patient and the patient's continuity of care. It has to be done and done correctly and promptly. I can't understate how important correct documentation is. Okay, so let's talk about some basics of coding. So I know that that seems a little like that's a lot because you're like coding. Oh my goodness! In medical assisting, it is a lot. But we're just going to cover the basics of what you need to know because it really does um, appear in your day to day life as a medical assistant working in a clinic. Um, Even though there are people who go to school for specifically for billing and coding, and it's not likely that you'll be doing the billing and coding, you're still going to see it. They're still going to talk about it because everything that a provider does is based off of what insurance will pay for, and how insurance will pay for things is based off what codes are put in. So you will see codes all the time. So let's talk about what those are. So the first one is the ICD-10 codes. That ICD stands for International Classification of Diseases. The 10 means it's the 10th revision. They revise these every so often. They add additional codes. We used to say, I'm going to age myself now. There used to be an iPhone commercial that would say there's an app for that. So we used to say there's a code for that because there really are diagnosis codes for everything. And we like our codes to be as specific as possible because a specific code means that insurance will more likely pay for it. So they give you an example of what that would look like. ICD-10 codes always start with a letter, and then two numbers, a decimal, and then another number. So most of them are four. Well, I guess it's one letter and then three numbers, 4 digits long, but they can be up to seven. So the longer the code, the more specific it is. So they give you this example of on the slide ELL.9, which is for type 2 diabetes mellitus or mellitus without complications. If it was something like related to a fracture or, like it could be something of, um, distal fracture, right radius, something like very specific. Once you get into like naming which side it is and as specific as possible, you get longer codes. CPT codes are current procedural terminology. Those are the procedure codes or the service codes. Those are always five numbers, so 5 digits. So this example is 99213, which is office visit, established patient, low complexity. So yes, there are codes that you put in to get paid just for the visit. But this also includes any like labs, imaging, anything like that. With any type of procedure or service would have a CPT code. Oftentimes, the super bill or encounter form will have the most common ICD-10 and CPT codes that are used in that facility, so that they can be just check a box, and it's already in there, so nobody's having to look up what these codes are. Um, HCPCS codes, Healthcare Common Procedure Coding System. These are codes frequently used by Medicare and Medicaid that go beyond CPT codes. These are services not covered by CPT codes. And a lot of times these are for like durable medical equipment, like wheelchairs, walkers. This gives you the example of blood glucose test strips. Um, and HCPCS includes CPT codes that are like level 1. CPT codes level 1 are covers items and services not found in CPT level 2, which are really important for that Medicare and Medicaid. Again, like mostly durable medical equipment or DME. Okay, so the purpose of medical coding, I would say the major purpose would be reimbursement. Insurance pays and reimburses based off of those codes. They also are used for statistical tracking, analyzing disease patterns, clinical research, communication across healthcare systems, quality measurement, how things like performance assessments, how things are working, and then for legal documentation as well. You'll probably hear me talk about it most from the reimbursement standpoint. Also included in that, in order for the insurance provider to reimburse the facility, those codes have to meet medical necessity, meaning that the services provided are beneficial to the patient based off the specific condition that they have. So it's really important that when a provider orders any type of service or procedure, lab, whatever it may be, that the diagnosis matches it for medical necessity. That protects the patient as well, because that means that they're not being charged or billed for things that they don't actually need. So the provider asks for, or the insurance company asks for justification for that. I will say that can sometimes go the opposite direction from protecting the patient, because the insurance company then gets to be the person that decides what's medically necessary. So just because the provider says that the patient may need this, the insurance company is actually who gets to decide that. I actually just read a story that said that there was a little girl who was born without the lower part of her arm, so really her wrist and her hand. She was born without it, and they tried to get a prosthetic approved through insurance, and their insurance deemed it as not medically necessary, and not just for that little girl. Like, that was the case for everyone, not medically necessary. And so they were trying to raise money to get her a prosthetic. I also know I have a personal friend whose daughter needed a hearing aid for one ear, and insurance deemed that not medically necessary, would not pay for it. So even though their healthcare providers, their doctors, whoever, say that it's medically necessary, the insurance company are really ultimately who gets to decide what is covered. I'm trying to not let my personal feelings about healthcare insurance enter too much into this presentation, but I have a feeling you understand me at this point. Coding at the correct level of service is also important, because there can be problems and repercussions based off coding incorrectly. Upcoding would be using medical codes to get higher reimbursement. So coding for things and diagnosing for things that the patient doesn't really have, or trying to order tests for things that aren't necessary to get more reimbursement. That's illegal and cannot be done. So a provider cannot do that, things like upcoding. Whereas also not a great idea is downcoding, so coding at a lower level. So there's documentation to support that they needed a higher level of care. That can be really a problem, because that could lead to lost revenue. So the provider is not getting paid for all the things that is being done, and that can be a problem. Billing and insurance claims, they are one of the most important parts of the revenue cycle. Making sure that accurate charge capture happens before claims are submitted helps to prevent delays and denials from third-party payers, which are insurance companies and government programs. Making sure that these things are done correctly really makes a difference on how the facility is being reimbursed. So we're going to talk about some ways that you do that. Insurance terminology, some of these were at the beginning of this presentation on that terminology slide, but I'll go through a few here because these are some things that you need to know. If you are not familiar with insurance, you're going to need to know these things. And I'm probably going to, if you're not familiar with insurance at all, as I explain this, I'm probably going to blow your mind. Because people who aren't do seem to be very confused. And this includes your patients. So, as a medical assistant, you need to understand these terms and how insurance works because you will likely be the person explaining to the patient how their insurance works. I cannot tell you how many times I've heard, I have health insurance. I should not have to pay for anything. That may be the case, but that they don't pay for everything. And the things that they do pay for have to be certain things and done in a certain way. So let's talk about some of these terms that you need to know. Premium is the amount paid usually every month to maintain insurance coverage. So this is how much the patient is paying to have this insurance every month. Now, whether that's like they have an individual plan that they're paying for, or it's coming out of their paycheck because it's through a group plan through their employer. Either way, it's coming out of their money. A copay, depending on what type of insurance plan they may have a copay, and that is a fixed amount paid by the patient at each visit. Frequently, there is a primary care copay. A lot of times it's like $20, $25. And then frequently there could be a specialist copay, and that can be like $40, $75, again, just depending on their plan. Unfortunately, everybody's insurance plan is different, which makes this even more complicated. The deductible is the amount that the patient must pay before insurance begins to pay. So they do not begin to pay right away. So the deductible can be anywhere from $500 to $5,000. Typically, the higher the deductible, the lower the premium. Meaning, if they want a lower amount that they pay every month, that means the deductible is going to be higher. If they pay a higher amount every month, their deductible may be lower. Again, depending on their insurance plan, who their insurance is through, all of that is completely different. And the great thing is that changes every single year. So that's fun. So even after the deductible is paid, a lot of insurance also have a co-insurance. And so that is the percentage of cost the patient pays after meeting the deductible. Oftentimes that's 80-20 or 70-30. So let me explain that a little bit. So let's just say that you have the lowest deductible possible at $500, right? There may actually be lower deductibles. I've never seen one, but there may be. Let's just say you have a $500 deductible. Okay. You go in for 2 visits at $250 each. So your first visit, you're paying the full $250. You go for another visit, that costs $250. You're paying the full $250. Now at that point, you've met your $500 deductible. You go in for a third visit, and let's just say this third visit was $100. Okay. You have a co-insurance of 80-20. That means that the insurance company will pay 80% and you're still responsible for 20%. Okay. So for that $100 appointment, you are still going to be responsible for paying $20. So even though you've paid $500 already to meet your deductible, you still, every visit after that, are going to pay 20%. So if every visit after that is $100, you're paying $20 every visit, if that makes sense. Hopefully it does. And that can be very confusing to people because they may think that because they have insurance, they don't have to pay anything, which is not true. They may think once their deductible is met, they don't have to pay anything, which is, again, often not true. The allowed amount is the maximum amount an insurance plan will pay for a covered service. So they may say, oh yeah, this service is covered, but this is how much we'll pay total for that. If it's over that, then, well, that's on you. So There's some insurance terminology for you. Um, Another term is an ABN or advanced beneficiary notice. This is given to Medicare patients. Medicare frequently does not cover services, a lot of services, things like labs, especially. And if that is the case, then the Medicare patient should be given an ABN form. And how that works is you would fill out the form describing the what is being ordered, so the lab, and then on that form it will say Medicare likely does not cover this service. It will cost this amount. And then they can decide to either receive the service and just pay for it. They can check a box that says receive the service and pay for it only if Medicare doesn't pay. So try to bill it to Medicare, and if they don't pay, then they'll pay for it, or they can decline the service. It has to be done before they have the service, because you cannot bill the patient after they've had this and this form was not signed. So this form has to be signed by the patient before they can receive that service, if they would like to have it. Again, depending on the cost, probably is what they'll make that decision. And that's an ABN for Medicare patients. Another thing that NHA likes to ask about is the birthday rule. For insurance, it helps to determine primary coverage for dependent children when both parents are insured. So the parent with the earliest birthday in the calendar year provides coverage. So that's the month and the day only. If their birthdays just happen to be the same, the one who has the longest established plan would be the primary. In divorce cases, typically there's a court order that says who should be the primary coverage. So again, if both mom and dad have insurance, healthcare insurance on their child or their dependent, the primary coverage, meaning who's getting billed first, will be whichever parent birthday, meaning their month and day, not the year, but the birthday. So let's just say if one is born in August and one was born in December, whoever parent was born in August, their insurance will be billed first, and then whatever's not covered, they'll bill to the second insurance. If their birthdays just happen to both be August, whatever, then whoever has had their insurance plan longer, that's who they'll bill first. If they were divorced or separated, typically there's a court order that determines whose insurance gets billed first. So different types of insurance plans. Again, we're going to go through this kind of briefly. Medicare, we'll talk about the government-funded plans first. So that's Medicare. Medicare has Part A, B, C, and D. We really won't cover C. So Part A covers inpatient care, hospital care, skilled nursing, hospice, and home health. That is at no cost of the Medicare patient, because if they are over 65 of retirement age, or if they have any type of severe illness like end-stage renal disease, they qualify for Medicare. And oftentimes they have paid taxes. When you get your paycheck, taxes come out. One of those taxes is Medicare. Goes to this. So it is at no cost of the patient. However, I would like to mention that it only covers inpatient hospital, hospice, and home health, and it only covers up to a certain amount. So if this person needed hospitalization for longer than what is covered, at that point, they will start billing the patient. That is Part A. Medicare Part B it covers outpatient care, preventative services, so doctor visits and appointments like that. This is not covered from those taxes, so the patient does have to pay in order to have Medicare Part B. So they pay a premium every month in order to have that. And then Part D, if you can remember D for drugs, that is for prescription drug coverage. Again, that is not covered. The patient will have to pay out of pocket for that. Medicare by itself, Part A does not cover prescriptions. for their medications. So a lot of Medicare patients will also have a supplement or a supplemental insurance to help cover some of these other costs. Medicaid is governed by the state versus the federal government. It is the state who determines who qualifies for Medicaid. It is for low-income individuals or those with certain illnesses or disabilities. And that is, again, determined by the state, what income level that would be. And Medicaid does cover everything. I will say that for both Medicare and Medicaid, there are a lot of clinics who do not accept those insurances because how that works is the Medicare and Medicaid will give the clinic or healthcare facility, this is how much we'll pay for this. So let's just say, this is an off the wall example, but let's just say a urinalysis costs $10 for them to run that, right? So Medicare and Medicaid say, we'll give you $3 for that. That's how much we'll pay you for that. So if it costs $10, that means that they're losing $7 every time there's a urinalysis because they cannot bill Medicare and Medicaid patients for those. So that means that the facility is just losing $7 every time one of those patients. And so a lot of facilities will not accept that because they will essentially lose money based off what type of care they're providing. TRICARE is for active duty service members, retirees, and their families. And TRICARE can be really tricky too because they want them to go to certain facilities, and if they're not like on a base, etc. If they're not near a base, then they have to have a primary care provider send a referral to be seen anywhere else for them to pay. So it can be a little tricky too. CHAMP VA is for families of veterans, disabled veterans, and it's very similar, or it's not very similar. It's somewhat similar to TRICARE, but it is. They're typically seen in a certain type of clinics and certain types of facilities. Workers' compensation, insurance coverage based off of work-related injuries and illness. So something happened on the job. The key thing to remember about workers' compensation is that if workers' compensation is paying for this patient's visits or whatever healthcare related to this injury, there is a separate chart for this because you cannot have their employer cannot have access to their entire medical record, only related to what happened from this job related injury. And then of course there's private insurance plans like Blue Cross Blue Shield. Blue Cross Blue Shield is the oldest and largest insurance company in America. The other ones would be like Cigna, Aetna, United Healthcare. I can't think of any more right now, but those are some other private insurance companies, meaning that the patient is paying a premium every month to have that insurance. Okay, so claim submission. So typically for outpatient services or in a clinic, which is what we would be most familiar with, a CMS 1500 form would be submitted. So once the patient has scheduled an appointment, came in for that appointment, insurance was verified, they were seen for the appointment, documentation of ICD-10 codes and CPT codes were done. All of that is finished. Then a claim submission form will be completed. In that claim submission form, the first section has the patient information or the insured information, because sometimes the person that's insured is not the patient. It may be their spouse or their parent or, et cetera. And so both the patient and the insured person's information has to be on there, demographic, their insurance details. Section 2 would be the provider's information, has all their information about who they are, provider numbers, etc. And then Section 3, I'm sorry, I did that backwards. Section 2 would be information about the services that were rendered. That would be like what ICD-10 codes they were, what procedure codes, what did they have done, and why. And then Section 3 is the provider's information for like the provider number, their signature, billing information, that kind of thing. These claim forms can be submitted. They're often submitted electronically. They can either be sent by direct bill, which means that the clinical facility sends in this claim submission directly to the insurance company, or they can be sent to a clearinghouse. A clearinghouse is a company that the facility is paying to essentially audit their claims and make sure that those claims are clean. So a dirty claim would be what we consider something that has errors. And if there are any errors on these claims, insurance providers will deny them. It could be as simple as someone transposed numbers backwards and they put 123 instead of 321. They would deny that claim. Or it could be that the patient was a female and they accidentally checked the box for male. They would deny the claim. Even if it was not relevant to that, it can be denied. So those would be what we call dirty claims. And so sending it through a clearinghouse they will go through that claim and make sure that it is clean and accurate, and then send it to the insurance company. And you're more likely to have payment or reimbursement from that, and less denials. So a remittance advice is a really important document. So after the claim processing, a remittance advice is sent by the insurance company that explains how the claim was processed. And this is sent to the healthcare facility, so to the clinic. It will say the services that they are going to cover, how much they're paying for each service, what the difference is for the patient. So in other words, the patient's deductible, what's left on that, if they have a co-insurance. If there were any denials, they will give the reason for the denial, like why was this not paid for. And so this is really important for the healthcare facility to have so that they can follow up on any denied claims, determine how much they will bill the patient for, and to track how much revenue they're bringing in. So that is really important for that. For billing and reimbursement, so for insured patients, you send that claim over for the insurance company first. And then once you get that remittance advice back, then you bill the patient. For uninsured patients, however, if they did not have insurance, typically payment is collected at the time of visit. They can arrange a payment plan. Oftentimes, if they're doing a cash pay or self-pay, the clinic will offer like a discount if they're paying in full. So it may be like it's a 20% discount or whatever. Or they'll set up a payment plan and say you have to pay this much today, and then we'll bill the rest for uninsured patients. So once the insurance company has sent the remittance advice to the provider, they will also send an EOB or an explanation of benefits to the patient. Be aware that patients will call and they'll say, I got this bill for this and this. My first question is always, okay, at the bottom, does it say, or does anywhere on this paper say this is not a bill? Because an explanation of benefits will always say this is not a bill on it. It's just explaining it. And if it does say that, I always tell the patient, well, let's just wait and see what the bill will be from the clinic. Or I can send them over to somebody in billing to talk to, and they can give them better answers. But I always say, let's just wait to that, because oftentimes it is different from what the EOB says. So once you get that, then there will be billing to the patient. So the patient will then get a bill for whatever is left over for the provider. So typically, all of this is done around the same time. So statements are sent out at a certain time of the month. So if you were just seen, 3 days ago, and it's now time for that, you may get a bill. If you may get a bill towards the later end of the month, if you were seen earlier and it wasn't time for their bills to go out. So typically, there's an initial patient statement sent out. If that has not been paid in 30 days, they send out a second statement. If after 60 days, meaning there's been 2 bills sent out, and nothing has been paid, a lot of times a phone call will be made saying, because you want, as the clinic, you want the patient to pay something. So a lot of times they'll offer payment plans, things like that. If after 90 days there's been no response from the patient and it has not been paid, there will be a final notice sent out. And then at that point, they typically send it over to a collection agency. So effective financial management is really important for medical offices for patient care and to ensure sustainability, meaning that they are profitable and that they have the ability to continue to function as a healthcare facility. So some of the things that have to be done in order to maintain that are accounts receivable management, which are tracking and collecting payments, payment posting procedures, accurate recording of payments, making sure that the correct account balances are there, financial reporting, budgeting, forecasting income, cost analysis, identifying and controlling expenses. As a medical assistant in this process, your job is making sure that documentation is accurate, that you are collecting any payments that are due, and staying on top of the things that you're responsible for in this process. Okay, so moving on from insurance and billing, patient portal technology. We've talked a little bit about this already. We've talked about telehealth and virtual visits, but patient portal technology are really important. It's a secure online portal that the patient can use, typically 24-hour access, utilizing the electronic record system. So that can be for messaging providers, scheduling their own appointments, rescheduling, canceling appointments, requesting prescription refills, having access to their records, test results, and of course, they can view and pay their bills online with these. Telehealth and virtual visits, which again, we've kind of already talked about, but they are typically used when you're scheduling and you need to schedule in something pretty short and quick, for medication checks, follow-ups, that kind of thing. You can do that. Your job as a medical assistant in a telehealth appointment would be making sure that the patient you have their correct info, that they understand how to access the telehealth appointment, kind of almost like the IT part of this. And then if there's someone who have barriers to this, then making sure that they get an in-person appointment if they actually need one. In all of these things, we follow our HIPAA privacy and security rules, because all of this is considered patient health information, whether that's the demographic forms that you get, the scheduling, the insurance information, all of this stuff we want to keep within our patient health information, and confidential and safe. which is why we use secure servers like Patient Portal to communicate with patients. Also, in this unit, we'll talk a little bit about workplace safety. We'll talk about that some more too, but this is one of the spots that they do cover some of that. And so there will be some test questions on our unit test about this. So I'm going to cover these real quick. Safety in healthcare is really important. We will talk about that all throughout. We'll talk about OSHA and some other things, but this will be a quick little thing here related to safety. Hazard identification, so being aware of any safety risks like slippery floors or spills on the floors, any equipment that's not safe. Part of any healthcare provider's job in the facility is making sure that there are no environmental hazards for themselves and for patients. Safety training, all staff has to have ongoing training like OSHA training, infection control, fire safety, and then incident reportings. When we get to phlebotomy, we'll talk a lot about the different types of incident reports. But for now, just know that you would have to document any injuries, any safety incidents. One safety measure for the healthcare worker is following proper body mechanics. Whether that you're sitting at a computer, you want to use the correct ergonomics, sitting with looking straight at the computer, feet on the floor, back up straight to prevent any neck and back strain. If you are reaching or twisting, use a step stool. Don't climb on things. Don't reach for things that are too far. Good body mechanics for picking up and lifting and making sure that when you lift, you bend at the knees, you hold the heavy item close to you. Have good footing and posture. So if you're doing a patient transfer or moving patients, you want to make sure that you ask for assistance if you need it, that you're protecting yourself as well as the patient. Safety data sheets. They are essential documents in any healthcare setting that has any type of hazardous chemical, and that could be anything like bleach is considered a hazardous chemical. And so you have to have these safety data sheets per OSHA. A safety data sheet has 16 sections that goes through each chemical, like the name of the chemical, what it's used for, like any hazards, like is it flammable, things like that. If you were to get it in your eyes, what do you do, or your skin, or if you drink it? So like first aid measures, handling and storage, if it has to be refrigerated or at room temperature. If it catches on fire, how do you put that out? All of that is in a safety data sheet, and those are required for any chemical in a healthcare facility. And then fire safety is really important. Evacuation procedures and fire response. We'll talk about this a little more when we get to emergency procedures, like CPR and things like that. But this is in this unit as well. So evacuation procedures and making sure that you're aware of the exit routes. You have to have at least, OSHA requires 2 exit routes from any given area with clear marked paths. And they should all be free of debris. Otherwise, that's a fire hazard. If there is a fire, we follow the acronym RACE, which is R for rescue patients and any personnel in immediate danger. A is activate or alarm. I see it both sometimes. So we activate the fire alarm, pull the fire alarm, call 911, the fire department, however you do that. C is confine or contain. I've seen it both ways. So confine the fire by closing doors and windows. So as you're getting patients out of rooms, close the doors behind you as you go. And then E is either for extinguish or evacuate. If it is a small fire, you can extinguish it yourself. If it is a large fire, you evacuate yourself as well as your patients and any coworkers. If it is a small fire that you're going to extinguish, we follow the PASS acronym on how to use a fire extinguisher. PASS, the P stands for pull the pin. A is aim. We always aim at the base of the fire, so the bottom part of the fire. S is squeeze, so squeeze the handle, and then the last S is sweep. Sweep from side to side at the base. If there is oxygen running in your facility, you want to make sure you turn the oxygen off. If you can, disconnect any oxygen supplies from the oxygen tanks, etc., because those are a fire hazard for sure. All right, let's see. Also included in this is inventory management, which is really important, making sure you have the correct supplies on hand. Nothing is worse than going to do a patient procedure and realizing you do not have the supplies that you need. So, as a medical assistant, it could potentially be your job to order supplies. So, with that, you want to make sure that you are keeping up with what supplies are needed and how much are needed. There are things called inventory tracking systems that you can use. There are some really awesome ones that are like you can scan things in to do that way. Making sure things are stored. Typically, the you monitor expiration dates. So, in other words, if you have new things, they go towards the back because you want to use the oldest first so that things don't get expired. First in, first out system. So, in other words, the older supplies you want to use first because we do not use expired items on patients. Okay, so the medical assistant administrative tasks are really important to the success of any medical office. That can be scheduling, anything from just appointment scheduling, making sure that that is done efficiently, following HIPAA compliance and confidentiality, making sure that patients are satisfied throughout the whole process, using the EMR appropriately, documentation, um, assisting with billing and coding things, making sure that the correct codes are marked and that patients understand their bills. All of this can be part of a medical assistant's role in administrative procedures.